Hello, friends. Good evening. The speaker that we have here is Dr. Avishek Roy. He is an associate consultant ICU in Apollo Multispeciality Hospital, Kolkata. Hello, sir. So you can start.
So, good evening, everyone. Today's topic of discussion from my side will be organ donation and transplantation, and I want all of you to kind of focus your attention to this part because this is not commonly read by intensivists. So, questions for this part could be a bit tricky. Okay, so the questions have been given to you. I guess I'll just quickly go through the questions and come to the discussion. I have a lot of things to discuss. So the first question is regarding the organ donation in UK. So which is true and false? So once a decision of organ donation has been made, the approach shifts from a patient oriented to an organ procurement approach, which is absolutely true. Regarding the donation after cardiac death, it is acceptable to delay the process of withdrawal of the donor until the donation process is started. It is also true. And because in after cardiac death, you have to optimize the patient so that you get some time for harvesting the organ. So it is acceptable to delay the process of life support withdrawal. And verbal consent before the death is enough to validate the organ retrieval posthumous status. It is true. So if a patient or if a donor wants or wishes to donate their organs and they have already declared either in verbally or in written terms their wish, it is acceptable that after death that can be done. Fourth point, family consent is mandatory even if the donor consented prior. This is false. So even if the donor has consented, there is a documentation that is enough to validate the consent. You don't need a family's approval. It must be more than 18 years, so there is no hard and fast criteria for donor age per se. Many different age group of patients are currently considered donors, even pediatric patients as well. So this is again a false statement. Second question, functional ischemia time begins from asystole. This is a wrong statement. False. Functional ischemia time, I'll come to the discussion that it starts from the point where there is a reduced perfusion. So when there is a reduced perfusion evidenced by severe hypotension or hypoxia, that is the point where functional ischemia time starts. Cold ischemia time is from harvesting donor organ till putting it in a preservative solution. Again, it is wrong. Cold ischemia time is purely when the organ is put in a cold preservative solution. So you harvest an organ from a donor, you put it in a cold preservative solution, your cold ischemia time starts, and then you again put it up, your cold ischemia time stops and attached to the recipient. So that again is a part two of the warm ischemia time. So this I'll discuss a little bit afterwards. So this is again false. Option 3, diabetic and hypertensive patient cannot donate kidney. Option is false. Controlled hypertensive can donate kidneys, and as per few guidelines, diabetic patients can also do it. So it is not a contraindication. Option 4, DCD is not suitable for heart donation. Absolutely correct, because donation after cardiac death means the heart has stopped, and therefore a non-beating heart is not an ideal candidate for a heart donation. However, there has been case reports where it has been done, but for the completeness of this question, I would say that option number 4 is correct. 5, noradrenaline first choice of fluid responsive, unresponsive patient. Controversial question to my guess, but the answer is false. I mean, incorrect. So the correct answer is vasopressin, which is given in a few MCQ books. The reason being that in a vasoplegic state, you don't have enough of your epinephrine or epinephrine stores, so you need to add something which adds except so are surrounding around this epinephrine receptor. So vasopressin acts by the V1 V2 receptors. This is a uh, vasopressor of choice. Although initial period obviously we add noradrenaline, but according to the question, this is a false answer. Question number 3. In DCD, worm ischemia time is lower than DBD. This is false. DBD has a lesser worm ischemia time. As per the Maastricht classification, class 1 and 2 are controlled donors. This is false. I'll come to the Maastricht classification later on. Special nurse can approach a family for donation proposal is true. Nothing to declare. discuss much about it. Fourth option, ICU team can alone perform apnea test is false. You need a specialized person like a neurologist or a neurosurgery person, at least as per the UK or the Indian standards. An organ retrieval should be done immediately following asystole. It's false because you need some time to for the procedures, for the paperwork, for withdrawal of support. So there are around 10 minutes even after asystole till when you can continue the support and you can harvest organs. And the longest harvested organ after donation is heart. This is the wrong statement. So actually the heart is the fastest organ that has to be harvested. Question number 4, 24-year-old male, severe TBI, comes with hypotension. Patient is found to be kind of non-salvageable, E1M1 status. Patient has urine output of 250 mils per hour, hemoglobin of 8, INR 1.8. So he has a kind of a severe brain injury with trauma-induced coagulopathy and severe traumatic brain injury, non-salvageable status. So basically meaning this patient is like brain dead, is considered like DBD. Now, with terms of donation, what should be the ideal next best step? So read the question. What should be the ideal next step in terms of donation? One is peripheral ephedrine boluses and more fluid bolus. This is wrong. You don't give much of peripheral boluses of ephedrine and much of fluid bolus because clearly this patient is not going to be much fluid responsive after 2 liters, which has been already given. This is the main important thing to remember. Number 2 is secure a CVC and start vasopressin arrange blood, thyroxine steroid replacement, desmopressin replacement, and 5% albumin. So the primary thing to manage over here, more than the urine output or the INR, is the blood pressure. You need to keep a map of more than 670 or systolic blood pressure more than 100 in these patients. So the correct answer is option 2. You need to secure a central line. You need to start NORAD and vasopressin early. Since the hemoglobin is 8 and target hemoglobin is more than equal to 10, you need to arrange blood. So option 2 is the most correct one among them. Others are partially true in many ways, but not the correct answer. Which of the following, question number 5, which of the following cannot be considered at all as donor? Control hypertensive diabetic patient for kidneys, known Hep B on tenofovir therapy for liver transplant, basal cell carcinoma who has received some amount of treatment but awaiting a heart transplant therapy, and disseminated tuberculosis with shock for liver transplant, and primary vein tumor without an extracranial spread. Option is option 4. So disseminated infection is a contraindication. Others are relative contraindication, but a controlled hypertensive diabetic, hepatitis B on therapy, a basal cell carcinoma, which is very much localized carcinoma, a primary brain tumor without metastasis can be candidates. Question number 6, which of the following doesn't interfere with the brainstem function? So the correct answer here is option number 3, severe head injury, GCS less than 8 and hypokalemia. So obviously your GCS has to be less than 8 in these patients. And hypokalemia, so potassium levels of 3 to 6 is acceptable. Unless the potassium is less than 3, it should not cause a problems while assessing the brain dead patients. I'll come to this in a later part. Others can be considered as confounders. So that these are confounders which can confound your brainstem examination. Regarding apnea test, which are true or false? If whole 10 minutes is not complete, apnea test is indeterminate. This is false. If baseline PCO2 is more than 50, it can't be done. It can be done. So again, option 2 is false. Oxygen passively given at 6 to 10 liters per minute via cannula is an ideal method that is described originally. It is true. Option 4 can be done solely by the ICU team is false, and a single positive test indicates brainstem dead. Again, a controversial statement, but as for the recent guidelines by the UK, New Zealand, and India, at least 2 times it has to be done. So this is a false statement. Option number 8. Now this after completing the brain donation. Now we are moving to our organ transplant, which is liver transplant. So sorry, this is not liver transplant. This is post liver transplant brain dead donation declaration, and this is a tricky question. It tells that 50-year-old male post acute liver failure, GCS 3 out of 15. You have done all the cranial nerve examination; they're negative, and you have decided to go for apnea test. During the apnea test, you notice that the patient has a particular movement. What is the movement? While you are stroking the feet, they have a flexion of ankle, hips, and knees. And sees that the nurse got scared and they thought that it's a withdrawal reflex, which means that the brain is active. What should be the best next step? So the question actually tests the examiner's knowledge about what are the spinal reflexes which can be present during apnea tests. So this is a spinal reflex. This is not a brainstem reflex, and therefore it is compatible with brain dead declaration. So this is not a sign of vitality. It is a pure spinal reflex. So the correct answer would be option number 4. You proceed with the apnea test as before. You don't do anything else. Option number 9. is a 12-year-old male had a history of fall from fourth-story building. I want all of you to focus is this question because I have not added any particular explanation later because this is kind of a trivia question. So look at the CT. You have a young male patient comes to it after history of fall. There is cerebral, it's decreased, diffuse cerebral edema. You can't make out your gyri and the fissures, and the patient has a typical CT finding. So this is known as a white cerebellar sign, which is suggestive of irreversible brain damage. So there are different stages of severe brain injury after a trauma. Initially, you have a loss of gray white matter differentiation. Initial cerebral edema will have some fullness of the gyri and the sulci, loss of sulci more importantly. And the later on stages, you have diffuse cerebral edema, loss of the cisterns, and this is one sign which is known as the white cerebellar sign. So because of the defective diffusion across the cells, the cerebellum looks hypertense. So the correct answer would be may involve organ retrieval bodies. So that's the correct answer is option 3. So this is suggestive of irreversible brain damage. Question 10, again a young male patient after a fall comes to ED comatose and has a cervical spine fracture. So for brain death declaration, what needs to be done? Apnea test declared the patient is true, is positive. Option 2, get an EEG done if detect. So this is a scenario where your ancillary testing comes at. This is not a scenario where you do go ahead with apnea. So the correct answer is get a cerebral perfusion imaging done, option number 3. So upper or higher spinal cord injury is a confounding factor for going ahead with the apnea test. As per the recent papers, this is again a kind of a tricky question, but I think people should be knowing it. And if someone asked about the recent updates, this can be asked. Which of the following has been discredited as a routine measure? Desmopressin for DI, steroids for vasopressor refractory shock because of HP axis suppression, vasopressin for unresponsive shock, or thyroxine for sick euthyroid syndrome. Correct answer is option 4. So routine thyroxine therapy post brainstem brain dead donor replacement brain donors for the purpose of harvesting organ has not shown consistently to improve outcomes or vasopressor requirements. So routine thyroxine therapy is discredited. Question number 12, 27 male, history of transplant 2 months back for alcohol-related cirrhosis, comes with history of community-acquired pneumonia. Patient is on tacrolimus and steroids. Gradually progressive shortness of breath you have noticed. So basically the patient is having a severe community-acquired pneumonia. Now the question asks which of the group of organisms is important or was responsible. So this tests the knowledge of the examinees on the post-transplant different types of infective agents that can be seen. Options are various spikes organisms. Spikes, I'll come to the full form. Aspergillus, Candida, MDR gram negative. Option 2, PCP, CMV, Listeria, CAP. Community acquired organisms only, or think about non-infectious cause. So the correct answer is option 2. So that the typical cutoff is 1 month, 1 to 6, and more than 6. Less than a month, you get all the hospital acquired infections and the gram negatives MDR. 1 to 6 months, you get all the immune opportunistic agents because of the immune suppression, like the PCP, CMV, hepatitis, and the BJ virus, all those things, BK virus, all those things come up as opportunistic pathogens. And option after 6 months, you have all the regular pathogens of CAP and UTI. So that's a correct answer is 2. Which of the following, I think this many of you will be able to do it. So the option number 1, that is sirolimus, is linked with option 3, that is hyperglycemia. Option 4, that is hyperlipidemia and skin rash. Option 2, that is mycophenolate, is associated with myelosuppression. Steroids is option C. Cyclosporin with option B. Question number 14, post LDLT, that is live donor liver transplant, has an SGOT, SGPT of 1000 and 1200, INR of 3.2, on vasopressor, pseudo-1 ultrasound. Which of the following is true and false? So this asks about a particular set of complications which is seen in post-transplant, post-liver transplant patients. This I'll discuss in details. So I'll just tell option 1 is false, option 2 is true, option 3, hyponatremia, hyperphosphatemia, this is false because hyponatremia and hyponatremia is bad prognosis, hypophosphatemia is good prognosis, hyperphosphatemia is bad prognosis. Primary non-function is possibility, can be treated conservatively, not. PNF requires a transplant. And fifth one is that HAT causes greater elevation. This is again false. I'll come to the discussion section for this. Which of the following is true? Budd-Chiari is a common cause of transplant listing due to ALF. It's false. Budd-Chiari most commonly causes chronic liver disease or an acute and chronic liver disease. Doesn't cause acute liver failure very commonly, unless less than 2 to 3% maybe. So this is false. Low alpha score is associated with specific for Wilson's. It's false. It's actually the higher bilirubin and low alkaline phosphatase which is associated with Wilson's. Steroid and ATG treatment is a choice for those with acute cell-mediated rejection. So this is, I mean, question-wise, this is true. Although I have marked this as false initially, but on a deeper reading, I found out this is actually an equivocal answer. So whoever has marked it true and false both get the marks. So steroids and ATG are the mainstay of treatment for any type of transplant. I'll come to the discussion of rejection and management in later on. Hypophosphatemia is a sign of healing liver. This is absolutely true. And fifth one, hypothermia has been shown to reduce blood loss from liver bed. This is false. Hypothermia can cause significant bleeding tendencies and coagulopathy. Regarding question 16, this is a straightforward. The answer is option 4, cerebral via and motor via brain. So 3 and 4 are correct options. Question number 17, all of the following are compatible with the diagnosis of brainstem death except. So some of the findings are compatible. You can find it in a brain dead donor, except for few. So sweating, tachycardia, spinal reflexes, absence of DI can be there in brain dead donor, but seizure is particular thing which is indicates some viable brain. It goes against the diagnosis of brain dead donor. This is a very important thing because this particular set of options and this particular topic is given universally in across the PACT modules as well and in Indian guideline of brain dead donation as well. So I would like to put it as an important question. 18, clinical exam of brain dead shouldn't be done if an IV insulin required for sugar management. It can be done. There is no response to stop stimuli. So the correct answer is option 2. That is, you cannot do a brain dead examination if you don't have an adequate response to top stimuli. TOF stands for train of force stimuli. This is a EMG kind of a thing where a needle is a particular set of electrodes are put over a group of muscles and small square root kind of potentials are generated and you get some muscle action potentials usually used in anesthesia for assessing muscle paralysis level. So if you have a top stimuli which there is after stimulating the muscle, if you get a twitch response, that means it's adequate response. The muscles are not paralyzed. If you don't get an adequate response to top stimuli, you don't have. So probably there is some neuroparalysis component, and because of that, you cannot declare brain dead. You have to go for other measures. So the correct answer is option 2. Option 19. So question 19, while checking GCS, you see this kind of a response. Upper extremity is kind of adducted and externally rotated and pronated. You have legs which are kind of flex, extension of legs and plantiflexion of feet. So this is a decerebrate posturing, which indicates an M2 status, right? So MGCS would be 2. All of the following are brainstem reflex except this is a very standard question. Deep tendon reflex, fourth of is a correct answer. So now I'll come to directly to the discussion portion. I have a lot of discussion, so please bear with me and I'll be going fast. So if someone doesn't understand something, please ask at the end of the question. I've got like half an hour to discuss. So brain dead declaration and donation. Brain dead is a damage to the cerebrum and the brainstem characterized by presence of all of the three. That's you have to have a coma, you need to have abnormal cranial function test, and you need to have absence of response to carbon dioxide. The potential confounders after the brain dead cannot be, because of which we cannot declare brain dead are numerous, among which neuromuscular paralysis is important. So, fulminant Guillain-Barré syndrome with multiple cranial paralysis, botulism, severe hypothermia, and variety of drug intoxication, especially neuroparalytic drug intoxication, neuromuscular blockade intoxication, baclofen toxicity, even a neuroparalytic snake poisoning. These are all important confounders. High cervical spine injury. So there was one question asked based on this. And locked-in syndrome is a medullary or a pontine kind of a stroke where you have preservation of the facial or especially the ocular movements, but you don't have any other movements of the body. So it might seem that the patient is dead, but the patient is actually quite alive. So the response to a caloric test, the pupillary response, as size is the main determinant factors in these cases. So if you have this kind of things, do not declare brain dead. You can do an EEG and ancillary testing, which I have declared later on for diagnosis of brain dead. Spinal reflexes are there even after brain dead the brain is not functioning, so they has to be differentiated from the proper reflexes, the brainstem mediated reflexes. And one of the spinal reflexes which are predominantly seen is a triple flexion, which is in which you do a stroke of the feet, you have a flexion of hip, knees, and ankle, simulating a withdrawal response. This I have taken from one of the common site, the MCRIT. So this is a flowchart as to how to go about a brain dead. So first of all, you should first see whether there is a scenario which makes you do a brain dead examination. So if you have a patient with high motor vehicle accident, severe brain injury, or acute liver failure, fulminant liver failure with brain edema, you can go ahead. Second thing to see is that patient has anything which are confounders. If the patient doesn't have any confounders, then we can go ahead and do the apnea test. If the patient has confounders, then you have to go with ancillary testing or the image based testing, and the image based testing are the gold standard for diagnosis. And in these cases, the nuclear scintigraphy of the brain is the gold standard for diagnosing brain dead based on imaging criteria. So important to remember that whenever there is a scenario, first you rule out the confounders, you see whether you can do an apnea test or not, and if a confounders are present, then you have to go ahead with your other tests. Now before apnea test, you have to do one thing that we have already discussed, that brain dead is coma, so GCS of 3, absence cranial nerve function test. So when you're doing the cranial nerve examination or the evaluation, you do the pupillary reflex, the corneal reflex, the gag reflex, the cough reflex, so and the dorsal reflex, which is also known as the oculocephalic reflex, and the caloric test, the oculovestibular reflex. So this is in order. So you do a examination of the patient, you do the cranial nerve examination. When they're absent, you rule out the confounding factors. If confounding factors are absent, you go ahead with apnea test. If confounding factors are present, you go ahead through the imaging. Now, the particularly what lab findings can be confounding. So these are the specific set of criteria. So if our ammonia level is more than 75, burn levels are more than 75, calcium outside of normal range, glucose not between 300 to 670 to 300, magnesium outside of 1.4 to 4, potassium 3 to 6, sodium 130 to 160, pH outside of 7.3 to 7.5, and thyroxine level outside of the normal range. So if those are there, you cannot declare the patient brain dead. You have to go for a ancillary testing, or you have to normalize them before you go for an apnea test. These are the different spinal reflexes which can be seen in a brain dead patient. And just go through the list. There is an enormous amount of signs which can be seen. We can have a decerebrate post type of movements. See, decerebrate or decorticate means that some brainstem action is there, but decerebrate type of eye movements is separate. You can have extensor posturing, you can have sometimes eye openings can be there, although eye opening or grimacing indicates a properly functioning brain, they go against brain dead. Sometimes in a rare scenario, a stimulation of nipple can cause stimulation of the eyelids and something like that. Or sometimes you can have myokinia, where you have abnormal movements of the facial muscles because of a spinal cord stimulation. That is also a very rare phenomena. But if you get anything above the shoulders, like your reflexes coming from the face, those mostly indicate a normal functioning brain. If you have any reflexes below the shoulders, like this head Lazarus sign, where you have bilateral arm flexion, abduction, adduction, and head raising to the chest, and endotracheal tubes kind of sway away, this is again a spinal reflex. Plantar response, respiratory like movements. So this is a set of things. You don't need to necessarily go through everything, but you have to differentiate the spinal and the proper reflex. And the way to do it is, first of all, spinal reflexes are reflexes which are repetitive, and except they don't involve the facial muscles normally, except for myokinia, which I said. So if you have a grimacing, goes against it. Next is EEG can be done to differentiate between the two, but again, EEG in a severe metabolic disease derangement could be isoelectric. So EEG is not foolproof. So in these cases, what you can do, if you have a doubt, you can simply go ahead with ancillary testing or image-based testing. Simple as that. There is a concept that if you have suspecting a drug intoxication, wait for 5 half-lives. But again, why would you wait for 5 half-lives? Some of the drugs can have half-lives in days. So you have to go for image-based study, image-based confirmation in those cases. Very small pupil point argues against the brain dead because it indicates either it's a pontile bleed or a hemorrhage or infarction. So mostly a small size pupil goes against us. So you need to have a fixed and dilated pupil, non-reactive pupil. And oculovestibular reflex, which is the nothing but the caloric test, in which you have to put a cold saline, which is ice cold saline, usually with temperature of 2 to 4 degrees inside the ear, 30 ml each ear, and you first put in one-sided ear, and you check for the response, which is remembered as COWS. If you remember your ENT days, COWS stands for cold opposite warm sim. So you have to have the fastest component or the faster component of the nystagmus, horizontal nystagmus, that indicates the side of the side of the nystagmus. That should be opposite when you inject cold, and warm is same. So you inject cold saline, so you expect that a normal response would be a saccadic movements, faster response, faster component would be towards a opposite side. And you have to wait for 5 minutes between the 2 ears so that one ear doesn't confound the other ears. Coming to the most important test that can be asked, or the single important topic among today's class, is the apnea test. I'll briefly discuss in 2 minutes. So, apnea test is done. The prerequisite is that first of all, there has to be something which leads to the brain dead. I mean, there has to be some suspicion why the patient is brain dead. Secondly, you have already completed your neuroclinical examination. You have already done your reflexes. Once they're negative, now you have to prove that the brain does not respond to our elevated levels of carbon dioxide. So you need to have physicians which are two two physicians which are not involved in the patient care, and more importantly, those who are doing the test should not be part of the transplant team. So they may have vested interest, they may have other interests. So that's why, for the sake of legality, do not include them. There is an informal apnea test. This is not important for exam purpose. Is that whether to go ahead with the apnea test or not, how to do? So when the patient is on ventilator, you just reduce the ventilator respiratory rate to the lowest level possible. If it is 5, it is 4, whatever is allowed, and then you wait for the patient to breathe, or trigger the ventilator. If there is no breathing response, simply the patient is not breathing, so you can go ahead with an apnea test. If the patient breathes during that time, you don't need to go for an apnea test, so why waste time? Next is prerequisite should be that you should not have confounders. You should not have neuromuscular paralysis. So neuromuscular paralysis is checked by the TOF. TOF means a train of 4 sequence, in which a particular set of stimuli given to muscles. There was one question asked on this topic. So TOF should have at least some stimuli. Out of the 4, at least 2 or 3 should come. If none of the responses come, means it's a deeply paralyzed muscle. You cannot go ahead with apnea test. Systolic blood pressure should be more than 100. Mean should be more than 75. And in the way to do it, if the patient is hypotensive, you simply add NORAD, give some fluids in order to raise the blood pressure. Temperature should be more than 36. Hypothermic patient cannot be done. And how to do it is that you pre-oxygenate the patient, you increase the oxygen to 100%, and after that you get a baseline ABG done. The baseline ABG is to compare afterwards, because you need to compare the later on ABG. So after the pre-oxygenation, you have to apply apneic oxygenation. Now, what ideally you can do is that you simply put the patient on CPAP, 100% oxygen, 5 CPAP. But our ventilators don't allow that, because they will go to a backup mode, which is a control mode. Your entire apnea test will be botched up. So what you can do is either you use a self-inflating bag that is used in pediatrics especially. So that's a bag comes with particular set of valves. Or traditionally what we do is you cut the nasal cannula. You put it through the endotracheal tube, open the oxygen at 6 to 10 liters, and wait for the apnea test to begin. Now, generally it is the rechecked or reconnected, and the ABG is drawn at 8 to 10 minutes interval. Now comes the tricky part. So what is a positive apnea test? So after 8 to 10 minutes of this procedure, if you draw an ABG looks like the pH is less than 7.3. So pH is less than 7.3 after ABG, and PCO2 is more than 60 with an acute rise of more than 20. Then it indicates that the patient has a positive apnea test, means the patient does not respond to carbon dioxide. The question is, supposedly the patient has severe hemodynamic instability in between, patient becomes hypotensive, hypoxic, what to do? At that point, you can draw the ABG at that point itself and connect to the ventilator. At that point also, if this particular criteria, that is PCO2 of more than 60 or 20 rise or pH less than 7.3 is met, again the apnea test is positive. So a 10 minutes complete apnea test is not mandatory. It can be done away with. Supposedly you at 10 minutes you find that the PCO2 has risen, but the cutoffs are not met. It has risen by 15 and the total PCO2 is say 55. So in that case, you extend the apnea test further, and to 15 minutes, 20 minutes thereon, if there is no hypoxia, hypotension, and you repeat the ABG at 15 minutes and 20 minutes interval. And last thing is that if there is severe hypoxia, patient on ARDS, you are suspecting brain dead, can you do an apnea test? You cannot do, because you cannot, for ethical purposes, you cannot detach the ventilator. So in those cases, you have to go for a ancillary testing, right? So these are the main conceptual things we have to know about. So ascertain the cause, these things I've already discussed. Now coming to the donation criteria. So you have done the apnea test, you have declared that the patient is now brain dead. Now we'll come to the donation. Who can donate, who not, and what is the management of a brain dead donor. So per se, there is no absolute contraindication. except for age of more than 80 in some organs, like for example, lung transplant, 65 is the age cutoff. So in those cases, you don't do it. Otherwise, age is not a strict criterion. Lack of significant past history, if you have two or more organ failures along with, there is a particular organ which is about to get transplanted for a recipient, I'm saying you don't need to, you cannot do a transplant. So a patient who is already having liver failure, kidney failure, they cannot undergo a lung transplant. Significant metastatic disease, if the this is for donors. So if the donor has significant medical comorbidities, significant metastatic malignancies, disseminated infection, these patients cannot donate. Whereas a recipient who has end stage disease, multi-organ failure, as I said, they cannot receive. And relative contraindications, again, some confined brain tumors, patients who are seropositive but not on drugs, this can be considered in rare scenarios. But again, patients on seropositive patients like HIV, HBsAg, hepatitis C especially, if they have taken their drugs regularly, they are good candidates for transplant. Now, coming to something known as a Maastricht criteria, one question was asked: controlled versus uncontrolled. So this actually comes from the Maastricht University, which declares patients of donors, which categorizes into five types. Four types was there previously. Now, a fifth type has been added recently. So category one is patient has been brought dead to the hospital. We don't know when the arrest occurred. So these are the worst kind of donors. You imagine that patient was found dead. Nobody knows what is the ischemia time for the organs. Option two is that unsuccessful resuscitation. You have tried to resuscitate, patient is died. So again, that is again uncontrolled. So one and two are uncontrolled donors. So they have worse outcomes if you transplant their organs to our recipients. So the one and two, again repeat, uncontrolled. Whereas 3 and 4 are controlled. 3 is cardiac arrest following a planned withdrawal of life support. So obviously you have planned your withdrawal of support. Although the patient goes into arrest, you have already kind of managed or manipulated their physiological milieu. 4 is either of cardiac arrest in a patient who is brain dead. So patient who is already brain dead, we are harvesting organs. If they undergo cardiac arrest, again it is a controlled scenario. And fifth is considered uncontrolled. That is cardiac arrest in a in-hospital cardiac arrest is controlled, uncontrolled. Now, this is the therapeutic goal. Supposedly, a patient has been declared brain dead. Now, their relatives have somehow agreed to the donation part. So, as an intensivist, what important things you need to maintain? So, you need to keep a normal heart rate. You need to keep the mean pressures more than 70, systolic or more than 700. A CVP classically has been said to be maintained between a 6 to 10 millimeters of mercury. Urine output more than 0.5 to 3 ml per kg per hour, or 75 to 100 ml per kg per hour is enough for adults. Electrolyte should be normal. Blood gases should be normal. Lung protective ventilation should be maintained. pH and PCO2 should be as far as normal as possible. Lactate should be negative or near normal as possible. Core temperature should be more than 36. And absolute contraindication, again, I have already discussed. So one of the question was there that which donors cannot be, who cannot at all donate. So basal cell carcinoma is one such, which is basically locally constrained. So basal cell cancer patients, their organs can be harvested after their death. However, if you have a patient with melanoma, disseminated melanoma of the liver, for example, skin plus liver, melanoma patients are not ideal candidates. They are contraindications. So it depends disease to disease wise. So read the question carefully. So how to manage brain dead donors? Normalize their blood pressure. So you assess their fluid responsiveness, start vasopressors, keep them normal volumic, keep their urine output normal. Optimize the lung function. So apply lung protective ventilation, optimal PEEP. You might need to do a bronchoscopy to go for a bronchoalveolar lavage. Maintain normal electrolytes and establish normothermia. Next is metabolic component. So if you have a patient with diabetes insipidus characterized by hyperosmolarity, that is sodium is increased, and hypoosmolar urine, you have to give desmopressin. Question is, what is the dose of desmopressin? Dose of desmopressin is 2 to 4 micrograms IV, Q 6 to 8 hourly. If you want to give intranasal, the dose is higher. It's in the range of 20 to 30 micrograms. That's one puff is 10 micrograms. So you have to give 2 to 3 puffs, 2 to 3 times a day. And if you have to give subcutaneous, the dose is usually between 8 to 10 micrograms subcutaneously 2 to 3 times a day. So you can give IV, subcut, or intranasal. If you don't have a desmopressin, you can give a very low dose like 0.6 units per hour of vasopressin infusion as well. You have to give normal temperature by means of warm blankets and forced air warmers. And Maastricht criteria I've already declared. And again, 5 criteria I've discussed. If the patient now, if the patient is brain dead, what important point to remember that they will undergo initially, there will be hypertension, there will be severe tachycardia and hypertension in the initial period, because their brain is now dying and their hypothalamus is now releasing whatever epinephrine and norepinephrine stores they had. And so because of that, they have a surge in the blood pressure and the heart rate. Immediately after that, they have a severe depleted hypoadrenergic state characterized as severe vasoplasia and bradycardia. So this is a normal response. So during this catecholamine surge stage, you can have end organ dysfunction, like your lungs can get damaged if you're planning for a lung transplant. Your heart can get ischemic if you're planning for a heart transplant. So you have to protect your heart and lungs at this stage. And neuroprotection. So you can have seizure, you can have the reminder of the brain cells. They can, because of this severe catecholaminergic surge, you can have other organs like kidneys and liver. They can also go into failure. So this organs management is very important. Now, because of the severe hypothalamic dysfunction, you can have you can have shortage of all the hormones. So you have to give adequate amount of thyroxine and methylprednisolone 15 mg per kg. So methylpred very high dose, and vasopressin. Vasopressin either for as a substitute of desmopressin or as a single dose, either can be given. As I said previously, nowadays there has been studies coming up which have shown that routine thyroxine doesn't help. So this is now out, kind of discredited. Lung transplant, you have to go for a supportive care bronchodilator. You have to send your bronchoscopy samples for any colonizers which is possible. Organ harvest time, one important point to consider is that if supposedly you have harvest, patient is dead, till what time can you harvest particular set of organs? So the shortest time is for heart, that is 4 to 6 hours. Longest time is for corneas, which can be stored for 14 days. Kidneys 24 to 36 hours. So this is the longest harvest time that can be done. Now the liver coming to some solid organ transplants, and I have asked one question on liver transplant. I will discuss liver transplant in a bit details, and I don't know if there are questions would be asked from it, but since this is the majority, I mean, this is the most tricky transplant that mostly happens in the world, I'll discuss this. Lung transplant also is coming up big time. Kidney transplant is pretty straightforward. I don't think that has much of a component to it. And cardiac transplant is not my field, because it's particularly important for cardiologists or cardiac intensivists to do it. So I'll discuss liver transplant in a small details. So liver transplant can be of different types. Orthoptic is when you transplant your liver to the recipient liver. That's the most commonly done, what we normally do. Split liver is when you split the donor liver, the diseased liver, into two parts. One part you give to one patient, another part you give to another patient. That is known as split liver transplant. Heterotopic liver transplant is donor liver is put alongside the recipient's liver. So recipient liver is there. It is there in its normal place. You put the donor liver alongside the recipient liver in some other bed. It might sound astounding or fascinating, but it requires significant get up skills. The donor liver can have lack of oxygen supply, blood supply, so it's kind of a tricky, not a straightforward thing. APOLT is the one which can be asked in exams. It stands for auxiliary partial optotic transplant. So imagine a patient having an acute liver failure. You remove part of the liver and you transplant the donor liver into that part. So donor liver is transplanted to its native place alongside part of the recipient's liver. So after the acute liver failure is there, goes away. So its normal liver also heals. So you don't need the donor liver at all, and you don't need immune suppression, because after the disease process heals, your normal liver, your recipient's native liver has already healed. So it involves transplanting a partial liver while leaving a portion of the native liver in place, potentially allowing for spontaneous regeneration and avoidance of immune suppression. Very important for pediatric patients or small patients. Okay, so this is APOLT. Coming to the most common etiology leading to transplant, it's either metabolic associated disease or alcoholic liver disease, viral and decompensated cirrhotics, alcoholic liver disease, hepatocellular carcinoma. These are important things. Now, once you are assessing the liver function, supposedly patient has underwent liver transplant, comes to your ICU. Now you have to assess the patient and address the patient. So what are the signs that a function of the graft are good? So if you have decreasing lactate levels, improving acidosis, decreasing phosphate levels, because once the liver cell regenerate, they will take up phosphate and potassium. So hypophosphatemia, hypokalemia is good sign, whereas hyponatremia is a bad sign. Similarly, if you have rising potassium, increased acidosis, increased lactates, Those are all bad signs. Again, if you have persistent organ dysfunction, persistent acidosis beyond a 12-24 hour window, they indicate a bad prognosis. A rise of transaminases is expected because you are handling the liver, but if it is elevated beyond 24 to 48 hours, it indicates bad prognosis. Um, so, graft dysfunction characterized by persistent acidosis, hypoglycemia, altered sensorium, and organ dysfunction. So, what I have asked one question that a young male patient, post-op liver transplant day 3 or 4, something like that, has coagulopathy, raised OTPT. So, what are the important things to consider? So, this patient can have a post-operative sepsis. They can have graft-related problems, which are mainly three: primary non-function, early graft rejection, dysfunction, and rejection. You can have vascular problems. So, vascular problems could be inflow problem, could be outflow problem. Inflow is like you have a hepatic artery stenosis or thrombosis, portal venous thrombosis, splenic artery still phenomena. These are the major three things. And a venous outflow obstruction could be in the form of an IVC occlusion, IVC thrombus, clot, whatever. And you can have biliary complications generally in the later stages as well. So this is one table showing the different complication after liver transplant time-wise. So immediate post-op, you get all the infections, the bleedings, and the vascular complications like the hepatic artery thrombosis and portal venous thrombosis, which are in the immediate period. Biliary complications generally they tend to occur late, say more than 7 days. Respiratory complications like pleural effusion, pneumothorax, these are things which are happen any day, any time in a ICU patient. You won't bother much about it. Again, shock, bradycardia, different arrhythmias are common in post-op patients, can be seen. Neurological complication, especially tacrolimus-induced PRES, posterior reversible encephalopathy syndrome, is one thing you should be keeping in mind regarding all solid organ transplants. So this is one important thing. And again, coming to rejection can be of different types. I'll discuss it. So coming to the management part, so you basically manage the patient's hemodynamics, you keep an adequate abdominal perfusion pressure, you reduce the intra-abdominal pressure by putting drains and everything, removing the ascites. And for fluid hemodynamics, fluid resuscitation, you need to use a tidal volume challenge test or an end expiratory occlusion test. Do not use IVC in these patients. Do not use a flow track because flow track is not for this kind of patients. And if you have a shocky patients with AKI, use Turley and NORAD upfront along with adequate albumin and fluid resuscitation. Avoid, diuretics as much as possible. And if you have a vasoplegic state with low SPR, you have to add vasopressins and you can add, other vasopressors like angiotensin also can be added. So coming to the other things important to manage is coagulopathy. So these patients can have coagulopathy. Don't think much about this coagulopathy part. If the patient is bleeding, number one. Number two, in those cases, get a TEG done, TEG or a ROTAP. These are viscoelastic tests. This tell you that what is exactly the component which is non-functioning here. So transfuse only if there is a bleeding and transfuse based on the TEG or the ROTAM study. If you have, so TEG ROTAM is discussed here. So supposedly, what are the components which gets deranged over here? So as this is already discussed in the chapter in the discussion of ALF, so that if patients have acute liver failure or post-operative liver dysfunction, they actually are much more hypercoagulable or eucoagulable as compared to hypocoagulable. So do not go by the INR values because they have an increase in the von Willebrand factor, thrombin generation, clot stability, and they have a decrease in the anticoagulants like the ADAMTS 13, CNS, plasmin, etc. So they have a balance maintained between the procoagulant and anticoagulant factors, and that's why you have to go for the ROTAM or the TEG-based study. So TEG and the ROTAM, this class is not about their discussion, so I will leave it to some other class if it is possible. I'll go to this. So you have to use them for guiding your therapy. Deranged INR less than 12 hours is common, but if it is persistent, again, it's a bad sign. And DIC and sepsis-induced coagulopathy have to be kept in mind. You should keep normal electrolytes in your ICU for these patients. Altered coagulation, again, this has been already been discussed. I'll not go into the details. How can you manage if you have a fine bleeding patient? You can use FFP. You can use cryo. Cryo is rich in factor fibrinogen, factor 8, 13, protein CNS. This is very important for MCQ purpose. You can use a fibrinogen concentrate. You can use a platelet concentrate, which is rich in 2, 7, 9, 10. You can use platelets if there is hypothrombocytopenia with bleed. And you can use something known as Novo 7. It's a recombinant factor 7. But the evidence is quite weak, so it's not recommended primarily. But many people are using it. You can use antifibrinolytic if your ROTAM or the TEG suggests a hyperfibrinolytic state. So coming to the management, particularly for this patient, so if you're post-operative, you'll see the LFTs, and your LFTs can be ranged till 24 to 48 hours. But there is a particular set of problems that indicate a particular set of vascular or graft dysfunction, which I'll come to later on. You have to monitor your drain output. Drain output, if it is bilious, indicates some bile leak, so that can be a post-operative anastomotic leak. Now coming to early and late post-tracheal extubation, I don't think it's much of an important. Just remember that if the patient has a lower MELD score of less than 18 and less requirement of blood products and blood, the patient can be extubated on table or at least less than 3 hours of ICU stay. But these are all rarely you can do it because most patients are complicated. At least in Indian scenario, they are mostly advanced liver failure. So you might need to ventilate it for 1 or 2 days or maybe more than that. Now, coming to a few things which needs merit. What is portopulmonary hypertension in this regard? Portopulmonary hypertension is simply pulmonary hypertension with cirrhosis. Grading I have already it's given there. So the 25, 35, 45. More than 25 grade 1, more than 35 grade 2, and more than 45 severe. Then hepatopulmonary syndrome is defined as when you have severe hypoxia with orthodeoxia. So patient on upright position will have more hypoxia. How do you diagnose? By doing a contrast enhanced echocardiography, by doing looking at the brain uptake or looking at the heart, and how to categorize them. So the normally if it is the PO2 is less than 80 with a PA minus A, that is alveolar arterial gradient of more than 15, that's diagnostic of HPS. Then the categorization of mild, moderate, severe, very severe done based on, so that's the categories goes like 80, 60 to 80, 50 to 60, less than 50 for the PO2 part. Management of graft function. Now, this is the important parts I want to discuss. What is primary graft malfunction? So, you have transplanted the liver, and because of some immunological phenomena, ischemic reperfusion injury, it does not function at all. So, in the post-op period, you have AST, which is through the roof, more than 3000, INR more than 2.5, acidosis, and lactate more than 4 within 7 days of liver transplant. This is known as the OPTN, that is the Organ Procurement and Transplant Network, that's situated in, I guess, US. So, based on their criteria, it is termed as primary graft non-function. So, you do an ultrasound to confirm, you rule out all the vascular obstructions and all. And if you find this criteria is met, you have to only go for retransplantation. There is no way this patient is going to get cured with medical management or supportive measures. Whereas an early allograft rejection, it is less severe as PNF. So the OTOF classification tells that if you have a OTPT of more than 2000 as compared to 3000 in PNF, bilirubin of more than 10 and INR of more than 1.6 at 7 days post-op or within 7 days post-op, it goes with the diagnosis of EAD. In that cases, you can use a conservative management and plasmapheresis. Mortality is around 30%, but you might need a retransplant. But you have an option of going for plasmapheresis. Coming to rejection, so rejection can be of different types: hyperacute, acute, chronic. Hyperacute is mostly preformed IgM antibodies. Okay, so preformed IgM antibodies, very hyperacute within minutes to days, and patient gets the liver dysfunctional within hours. So there is no treatment other than transplant. Acute is what we are basically treating. It develops within few weeks to less than 6 months. Majority of them are because of T cell, where the T cell works as an antigen. It gets stimulated because of the antigen presenting cells, and now they trigger all the immunological artillery, so that the donor cells are hampered and you have a graft versus host kind of a reaction. For that, you need immunosuppressants, which is given in the initial period. You give steroids and ATGs and biologics, and in the chronic stage, you give some other drugs like CNIs, MMF, and other drugs. So chronic rejection usually takes years. Chronic has multifactorial etiology. Among the acute rejection, it could be either a T cell mediated or a B cell mediated. If it is T cell mediated, then you have to use a combination of steroids with T cell suppressing agents like CNF, CNIs, that is calcineurin inhibitors, and mycophenolate mofetil for the treatment purpose. But if you're dealing with an acute antibody mediated hyperacute rejection, which is rare, but it can happen, you have to reduce the antibody levels. You have to use steroids, ATG, tacrolimus, and one thing I missed out for here, you can use rituximab, an anti-CD20 antibody which acts against the functional B cells. So rituximab is used in antibody-mediated resistance, right? Now coming to there is a bank working group criterion as to how to differentiate mild, moderate, severe classification based on liver biopsy. So many of these patients have difficulty in diagnosing them. Okay, we have dealing with sepsis or we're dealing with primary organ dysfunction or liver failure. So in those cases, liver biopsy is required. This is not important, just the band name is important here. And I'll come to the management of acute rejection. So acute rejection in the initial period, you go for steroids, pulse steroids at 15 mg per kg. You go for ATG. You might need retransplantation. Chronic, as I said, is multifactorial. There was one question asked on the side effect profile. So steroid side effects, you all know. Now coming to antimetabolites. So purine, all the purine like azathioprine, anti-purine, they blockade the de novo synthesis of the purine. MMF is mycophenolate mofetil, again an anti-purine agent. These things are associated with bone marrow suppression, and MMF is associated with mostly gastric side effects, like you have a GI intolerance and all those. CNIs are calcineurin inhibitors which suppress the T cell activity. So these are useful for T cell mediated acute rejection, preventing them. So the agents are mostly cyclosporin and tacrolimus. Tacrolimus is preferred in many ways. Their side effects include nephrotoxicity, hyperkalemia, and weight gain, gingival hyperplasias. So these are all the common side effects that we can look at it. The newer ones are antiproliferative, the mTOR inhibitors, mammalian target of rapamycin inhibitors, namely the everolimus and sirolimus. So these agents have the side effects of having skin rash and hyperlipidemia, and few biologics like antithymocyte globulin used in the acute period or at 1.5 to 3 mg per kg body weight, or something known as a basiliximab, interleukin 2 receptor analog. Baxay is the basiliximab. So these are all different modalities by which you can tackle an acute rejection. Now there is a preventive stage, there is a treatment phase. I'll not go into the particular details because this is not about transplant in details. But mainly in the acute phase, you use steroids and other agents. In the chronic phase, you stop steroids because steroids have a lot of side effects, and you go for a combination of CNIs with MMF or CNIs plus mTOR inhibitors. And you have to obviously keep track of the drugs levels and how they are compliant, how the patients are compliant. So this I'll not go into the details, the induction regime, how they are going, how they are combined in different toxicities. CNIs, tacrolimus, as I said, is preferred because of increased potency and monitoring potential. Therapeutic drug monitoring is important for all these drugs. And as I said, the adverse effects, CNIs have nephrotoxicity, neurotoxicity. Cardiovascular wise, they are very much unstable. If the patient has a history of CAD, or any other heart failure types things, you have to prefer an mTOR inhibitors in them. However, mTOR inhibitors can cause bone marrow suppression. So MMF and mTOR inhibitors can cause bone marrow suppression. Now coming to the other parts of liver transplant management. So we have talked about the different graft related problems, the rejection and their management. Now coming to something known as a small for site syndrome. Just imagine a pediatric liver. You have taken a small, like 8-year-old kid's liver is taken and you have put it in a 25-year-old male. What will happen is the liver will be smaller as compared to what it should be, and therefore it will be overwhelmed. So it will have both signs of ischemia and passive congestion. So it will have raised OTPT, it will have cholestatic features, and you have patients with splenomegaly, you have ascites. So this is typically seen in small for site syndrome. Only thing to note here is that there is something known as the recipient is to graft ratio is to weight ratio, graft and weight ratio. So if your graft and recipient ratio in terms of weight is less than 0.8, that indicates that it's a smaller graft that you are harvesting. Coming to vascular complications, I'll just notice how many slides are there. Do I have adequate time? Because I need, probably I need 5 to 10 minutes more. I guess I'll go ahead with it because I need 5 to 10 minutes more. Okay.
Sure, so you can take it.
Okay. So coming to the vascular complications, which is very important, and one question was asked among them. So I'll just put forward the concepts. So you can have inflow obstruction of the liver graft. So you can have hepatic artery and the portal vein at the major supplies of liver. They can get blocked. Portal vein is the major supply of liver. Hepatic artery is the secondary supply, 25 to 30 from the hepatic artery. So in hepatic artery thrombosis, you get enzymes elevation at the range of say 1000 to 1200, not more. Less than that, 300 to 400, not more than that. Whereas if you have a portal venous thrombosis, you have the majority of the blood flow is ceased, and therefore you have higher levels of enzymes. So the ways to differentiate a hepatic artery thrombosis and portal venous based on the lab is that HAT will have less amount of OTPT elevation, PVT will have higher amount of OTPT elevation. This is one tricky thing. How you diagnose? You call a radiologist and do an ultrasound Doppler. and there is something known as a resistant index. Resistivity index initial period has to be low, it has to be high. So in the initial period, a high resistive index is kind of normal. If it is low, it's abnormal. But later on, if it is low, if it is high, it indicates abnormality. More than 0.8 indicates abnormality. I'm not going to the individual details because it's extremely technical, but you have to know that. Just remember, if you can remember, the resistivity index is to diagnose a hepatic artery thrombosis based on Doppler examination. Portal vein thrombosis, it usually manifests as, again, raised enzymes. Since portal vein thrombosis obstructs the splenic vein flow, so it will cause splenomegaly and there can be variceal bleed in the long term. So it can have chronic stages. Portal vein thrombosis can behave like a left-sided portal hypertension. You don't get much of an ascites, you get a lot of splenomegaly and the variceal bleed, and you manage just like portal hypertension. You give beta blockers, you go for TIPS, you go for the variceal bleed management. And for an acute stage for portal venous thrombosis, if you are lucky, you can go for an endovascular procedure like thrombectomy, or in an unlucky stage, you can go for retransplant. There is something known as splenic artery Still's phenomena that sometimes, despite adequate proper technique of the surgery, you see that the spleen is getting enlarged, the liver is getting ischemic, not functional liver, however, there is no clot. So what happens is the flow from the hepatic artery directly going, instead of going to the liver, is kind of stilled by the splenic artery and goes to the spleen. So the spleen gets engorged and the liver is deprived of its original blood supply. This is known as splenic artery still phenomena. Risk factors are, there are few like some technical things. Sometimes ischemic reperfusion injury, warm ischemia time, multiple things are proposed. But the major thing to remember that they're diagnosed based on splenomegaly. You do an ultrasound and you measure the splenic artery flow is to hepatic artery flow, the ratio. It should be more than 150%. And the last is the outflow obstruction. So we have discussed the inflow obstruction. What will happen if there is an outflow obstruction like a Budd-Chiari syndrome, hepatic venous congestion, or an IVC thrombus? You get just like an acute or subacute kind of a failure with hepatomegaly, congestive changes, cavernoma formation, and portal inflammation and cholestatic kind of a picture you will get. So the therapy depends on the type of obstruction, the degree of obstruction. You might need to go for a embolectomy or you might need to go for a retransplant in these cases. Biliary complications usually present more than 7 days. So usually within a first week, biliary complications are rare. Risk factors are high MELD score and use of Cates T tube. And there are some risk factors like LDLTs, T-train placement, DCDs, that is donation after cardiac death, etc. Infection management in post-transplant, I'll discuss it now. So the most important, this I have already discussed in details. So this already discussed vascular complication, biliary complications. Post-transplant AKI does not require much of a discussion, that it just needs prevention. If it is there, you adequately maintain the volume status. You do an ultrasound focus, look at the volume status, maintain adequate volumes, give vasopressors if required, avoid diuretics if not needed, and give terlipressin or ordinarily along with albumin. Okay. Now, renal function, AKI, this thing I have already done. Neurological complication, one thing to remember, these patients can have post-operative seizures, especially if the patient is on tacrolimus, because they can cause toxicities and they can cause atypical press. Atypical press is a side effect of the CNIs. This is one MCQs which can be remembered. Nutrition is same as that of other normal liver failure patients. You need to give adequate amount of nutrition to these patients. I'm not going to the details. Patients of post-liver transplant can have long-standing hypertension and diabetes. So the prevalence is quite high. Now coming to one question which was asked, that patient with CAP, post-cirrhosis transplant 2 months CAP, what organisms are you looking ahead? So this is the chart we are looking at. So less than a month, you're looking at hospital-acquired pathogens and resistant pathogens like MRSA, vancomycin-resistant enterococcus, all the fungal organisms like Candida, Aspergillus, and wound-related infection, anastomotic-related infections, donor-derived infections, like if the patient was having some HCLV, LCLV, West Nile virus, etc. At 1 to 6 months, you have the opportunistic infection. So remember, if you are giving a cotrimoxazole prophylaxis to this patient, which is normally given, a Cotri 1 DS tablet, 1 tab alternate day or 2 tabs alternate day. If you are giving that, you cannot have a PCP. So pneumocystis pneumonia is common in a 1 to 6 months period if you are not giving PCP prophylaxis. But if you are giving it, it is very, very uncommon. You cannot have. So in those cases, you have to think about a CMV reactivation, Epstein-Barr reactivation, and other fungal organisms. Like you can have a Cryptococcus neoformans, non-tubercular mycobacterium, very important, especially for lung transplant recipients, liver transplant recipients. You can have it, and with also viral reactivation like cytomegalovirus is also can be seen. And after 6 months, it's just like normal community acquired patients. This is the chart you have to remember. Cytomegalovirus, I'm not going to the details. It's an important thing. It can get reactivated if you are having a positive donor and a negative recipient. Treatment includes valganciclovir and ganciclovir. There is one prophylactic dose, one is systemic dose, therapeutic dose. It's just prophylactic is half of the therapeutic dose. That's what you remember. Diagnosed by biopsy, the quantitative DNA assay, and a PP65 gene antigen assay. Coming to after the initial management, side effect profile, this has been described. And last part of our today's topic is something, 2 or 3 points about lung transplant. Although it is not so commonly asked, but since the lung transplant numbers are coming up. So lung transplant is generally done in patients with COPD. So it's mostly lung transplant is done in COPD, severe interstitial lung disease, or severe sarcoidosis, or cystic fibrosis, etc. These are the main indications. Where do you go for lung and heart transplant? So lung and heart transplants are done in cases of Eisenmenger syndrome. That's why when you have a left to right shunt where you have a reversal of shunt, or in cases of lung with a severe right ventricular dysfunction. Remember, normal COPD with corpalmolel, you only need a lung transplant. You don't need a heart transplant because if you treat the lung, your corpalmolel is gone. The donors of lung transplant should have adequate oxygenation, characterized by PF ratio more than 300. Lung complaint should be more good, and they should be never smokers. No smoking history should be there. Relative contraindications include the age itself. Single lung recipients, the recipient's age should be less than 65 for single, and double lung less than 60. If the patient is currently having smoking, and if there is history of any thoracic surgery, etc. And heart transplant, for heart transplant, one thing is to remember that the heart after harvesting needs to be kept alive in a special device scenario. That is, the name is there, so that requires a special kind of a setup. And if what in terms of lung transplant, sometimes a single lung transplant is good enough for COPD and bronchiectatic patients. You don't need a double lung transplantation for that purpose. And for the single lung transplant, you do a posterolateral thoracotomy. For double lung transplant, we have sternotomy and anterior thoracotomy. Rest, whatever the things I have told about management of liver transplant, that is the graft dysfunction you have to manage, the infection you have to manage, the nutrition you have to manage, what are the signs of a bad functioning one, bad functioning organ. Many things are having overlap with that of the lung transplant. So if you just know that a solid organ transplant needs an adequate immune suppression, management of the infection, and early detection of complications by means of ultrasound and radiology, you can manage any patient. Lung transplant, obviously, if the recipient is coming with severe hypoxemia, they might need ECMO. So ECMO is having a great role in bridge to transplant therapy. And follow-up of lung transplant has been shown that it does not have significant amount of prognostic benefit. At 1 year, although 80% patients are alive, at 5 years, less than 40% are alive, all over world data. So it's not that much promising, but again, it promises the patients around 5 years of life. These are the main concerns in these patients. With terms of respiratory, you can have primary graft dysfunction characterized by acute hypoxemia, bilateral infiltrates, pleural effusions, etc. You can have ventilator induced lung injury. You can have decreased mucociliary clearance, mucus plugging unit in the bronchoscopy. Post surgery, you can have a diaphragmatic palsy because of phrenic paralysis, vocal cord paralysis. You can have gastroesophageal reflux, gastroparesis. Cardiovascular, all sorts of arrhythmias, fog, hypotension, cardiomyopathy you can have. Neurological and surgical, same as liver transplant. You can have bilidium. Surgical, you can have surgical bleed, anastomotic lead, some infections which have harvested from the donor itself. So this is a short outlook of the cases. That's it. That wraps up for today's class. I'm open to any questions. So this I have intentionally covered a lot of topic in fast manner. I have not particularly gone in depth of individual topics because today's class is more on the individual questions and how many things you can cover. So that's it for my end. Any questions that you have, you can ask.
Students, if you have any questions, you may ask now.